Good morning, or good afternoon, or evening to wherever you may be tuning in from. I am delighted to welcome you to the last event of the spring semester at the Rising Powers Initiative at Boston University. The Rising Powers Initiative, which was launched this January, is an interdisciplinary, policy-relevant research program that we have put together that studies 5 emerging powers or blocks, so China, India, Brazil, Germany and the European Union and ASEAN in the context of 3 areas: security and cooperation, diplomacy and governance, and health and human capital. And so our last event today is on the 3rd issue area of health and human capital. And I'm going to turn it over to my colleague, Professor Mahesh Karra, who is core faculty at the Rising Powers Initiative. Thank you so much.
Great. Thank you so much, Professor Miller. I'm really delighted to be the moderator for today's session on demographic trends in the making of a superpower. This session and panel is motivated by the question around the role of population, demographic transitions, and the size of the working age population as most countries transition from youthful populations to older age and elderly populations. And we have 2 key experts to talk to us about how the role of population health and developments of countries has implications on their roles as rising powers in the global order. First, we will have Professor Jennifer Sciubba from Rhodes College. Jennifer Sciubba is the Stanley J. Buckman Professor of International Studies and Department Chair at Rhodes College in Memphis, Tennessee. She studied at the Max Planck Institute and is an expert on political demography and has published many, many books. She's a member of the Council on Foreign Relations and also on the board of the Population Reference Bureau. And she'll be presenting first on the role of population aging and the working age population on security. Then we will follow with Professor Joe Harris here at Boston University. Joe Harris is an assistant professor of sociology at BU. He conducts comparative historical research that really lies at the intersection of sociology, political science, and global health. He's done a lot of field work and he's an expert on South and Southeast Asia. And he'll be really discussing the role of health systems and health investments and what the role is of global health on national security and the international global order as well. So without further ado, I'd love to give the stage to Professor Sciubba. Jen, by all means, take it away. The floor is yours.
Sure. Thank you so much. I'm so pleased to be here today and to be working more closely with you all with the Rising Powers Initiative. I think it's great to draw attention to this particular segment of countries in the world. And so the way that I approach this as a political demographer, anybody who's watching this, when we read about population in the news, it's the extremes usually. We're either talking about countries that are way too old, that's how it's usually presented. Our vanguard of aging states like Japan, those in Europe, particularly Western and Southern Europe and North America, or we're talking about countries on the other extreme that are way too young. Right now, of course, in the news, the United States is talking about, which is a classic country of having, very high fertility, very young populations. So it's a Goldilocks situation is the way I think about it. Remember Goldilocks, she has her porridge and one's too hot and one's too cold. She's always looking for the one that's just right. Well, that's really what we're talking about today is we're talking about what if instead of being too old or too young, the demographic conditions are just right. So that is what I want to share with you today. So if we think about what role does demography play in the making of a superpower? I just want to break it down simply to think about 2 aspects of this. One is peace and one is prosperity. Let me get it to go forward here. Okay, this is the only text-heavy slide that you will get, but it's quickly to explain a demographic, some structural conditions we have here. So one of our demographic phenomena about is a window of opportunity. So if you imagine a country with really high fertility, their proportion of population that's at the very youngest ages is high relative to those of working age populations or older ages. And so we often talk about a window of opportunity is a phrase you'll see where a population's age structure has matured because of lower fertility, typically, to have bulk of the population of those working ages. So relatively fewer old age and younger dependents compared to the middle age population there. And for the longest time, as scholars, we talked about it as proportions. We looked at children under 15, less than 30% of the total population, and those over 65 or under 15%. My colleague Richard Sankata has really tried to bring that down to a one number, which I think is smart. So for anybody who's researched to policy communities, or I mean, even for me, it's easier to remember 26 to 40 years. So median age of around 26 to 40 years is what you're looking at for the window to open and the window to, of course, close. The other concept that you will see floating around is the concept of the demographic dividend. And of course, this is relevant to the window of opportunity. It's the bonus that you might get when the proportion of your population that is supposedly of these productive ages is putting into the system, and there are fewer people taking out of the system and dependent. But of course, as we're going to talk about for the next few minutes, just like my retirement account, you only get a dividend if you actually invest. So you can't, I'm not going to get any money, I'm not going to make any interest on my retirement account if I haven't put any money in it to begin with. And so really, the danger would be in thinking that the structural conditions alone, that the age structure alone gives you some sort of dividend. And it's called a window of opportunity for a reason, and that is that you have the opportunity to make the most of it. The second structural condition that I'll mention is urbanization. And we all know urbanization is, well, I will say this. When you review the literature on the relationship between urbanization and economic growth, and Mahesh may have more to say about this, it actually is, there's some mixed findings about it, but we do know that, at least theoretically, urbanization will reduce transaction costs, make public investments in infrastructure and services worthwhile, and promote the exchange of ideas. I think Matt Ridley is the one who says ideas have sex when they're close to each other in urban areas, which is an easy way to remember it. Okay, what does this look like? All right, what I've included here is one of the too young. We'll start with too young and I'll end with too old. So what does it look like when we're not yet in the window of opportunity? This is the Fragile Index put out by the Fund for Peace. This is just 2020 numbers, and this is the top 10 countries. And you can see here tremendously high proportions of population under the age of 19. And so the question we should be asking, of course, is how on earth do you govern a country where half of the population is children and adolescents? How do you build an economy around that? And as you can see from this list, the answer is often that you don't. It's really difficult to do so. So we might have a solution then. Okay, well, if we work to reduce fertility by letting women choose the number of children that they would prefer, empowering them with access to family planning services and so on, then the population age structure will mature, that median age will rise, and then everything will be better. But here's another case for you. So what happens when fertility actually does decline? If you were to cut off Tunisia's population pyramid here, by the way, this is males on the left, females on the right, and the population in 5-year increments rising up here. If you were to cut it off here, you could see a really classic pyramid shape, which shows that we had higher fertility. So the mommies here would have been having more than enough babies to place them, over 2. But as you see the fertility start to, as you see the pyramid going down here in 2011, that shows that fertility had been on the decline. But what we noticed in 2007 is that those Tunisians between the ages of 15 and 29 were 43% of all adults. And linked to the Arab Spring was that they had very little prospects for meaningful engagement in the areas that matter. They were excluded from political voice, but they expected to have it. There were few meaningful job opportunities, but they had expected to try to make a living. Many of them were doing worse than their fathers had been doing. And then they were excluded from social structures as well, because often marriage is closed out when you don't have a job. So relative to the generations before them, this group of people was worse. And that really set some underlying conditions for the Arab Spring to emerge. Demography is never alone the thing that determines that, but it's really it's like setting the stage for it. There was a spark that happened, but this was the fodder for the flame. So it's not automatic that by having an older age structure, everything will be hunky-dory. But we do have examples where things have gone well. So if we turn to, instead of just thinking about peace, we might think about prosperity. We can give the case of East Asia's rise to power here. So in the 1960s and 70s, many countries in East Asia instituted family planning programs, and they really tried to educate the children that were born into the society. So doubling down on education, investing in family planning. And we had some economic benefits from that. Many of the folks that Mahesh has worked with over the years are the ones who have led the studies to show how declining fertility had stimulated savings, facilitated investment in human capital, and ultimately wage growth. We also know that they rapidly urbanized. So in just 65 years, the proportion of East Asia's urban population more than tripled, from 18 to 60% by 2015. And in those, that's compared to the developed regions that had urbanized first, the same growth took about 80 years. So it was faster. We can see the result of the declining fertility in the rise of median age here. And I've included the Philippines as a comparison, but you can see, of course, this blue line here is Singapore, and then Taiwan, and then we have this kind of brown line, the South Korea, and the grayish line is China and the Philippines down here. So you can see, of course, that we have today median ages that really would have been unthinkable 50 years ago, rising well above 35, above 40, and really very soon going to be over 45 years. And how rapid that was. The same type of demographic transition for Europe took about 150 years. So this was very fast. What about a point of comparison here? So when we talk about what's the next group, can East Asia's rise be replicated? We might look at South Asia. So here, looking at Bangladesh and Pakistan, both in the year 1955, you can see a very classic pyramid shape. We know whenever we see this, that means there's high fertility. And from 1975 to 1980, both of these countries had nearly total fertility rates of 6.6 children per woman. But just 3 decades later, it lowered tremendously in Bangladesh, and you can see the difference between Bangladesh and Pakistan today. You can look at a couple of things here. Look at the total population for both countries. Look at the total population for both countries here as well. Bangladesh's fertility now is, I think, projected to be about 1.9 children per woman between now and 2025. Pakistan's is about 3.2. But the structural conditions are only part of it. To go back to that text-heavy slide where we talked about what else is there, what are the other ingredients, Bangladesh has really been focusing on rising exports. Remittances are still a big part of the economy, and they're rising, but they're declining as a proportion of the economy. FDI is increasing as well. So they are setting up the conditions to reap their demographic dividend in a way that Pakistan is not. So 2 places that used to be comparable are really diverging here. Now, still 2 million people entering the workforce every year. There's still some mismatches between the types of skills that are present among the population and the labor needs. But many of the other conditions, the literacy rate, for example, 94% of young women are literate in Bangladesh, but only 67% are in Pakistan. Bangladesh's window of opportunity is open, so they could start to reap that demographic dividend, and it doesn't close until probably around mid-century, but depend, of course, on the pace of fertility declines. Pakistan's window is not yet open. It won't really open until 2035, so the next decades are key to getting the country on track. Here's another point of comparison for rising powers. So although in our initiative we talk about India, Brazil, and we compare these two countries, they're really quite different in many ways. There are some data issues with India's urbanization. I will say that from the get-go. So it's possible that urbanization rates are higher than what's reported, but what is reported is lower than what Brazil was in 1955. Brazil and most of Latin America is saturated in terms of urbanization. We see a major difference in GDP per capita. This one I think is interesting too, if we want to think about even the next group of rising powers, potentially putting Ethiopia in here, which has seen some changes in its fertility rate. So what this shows is the average annual rate of change of the urban population, how fast it's changing, and the percent urban. Of course, Brazil would have a declining rate of urbanization since they're saturated, so that's no surprise there. But India, you want to look at this orange line here and the yellow. Oh, sorry, I meant for those to be the same color. But we see that India is just not urbanizing nearly as fast as even Ethiopia would be. Again, that makes some sense when you're starting from a much lower, I mean, look how low they are, a much lower proportion. But most scholars have pointed out that India could have been doing this faster and could have perhaps been reaping more of the urbanization dividend as well. Okay, only two more here. Nigeria is another country like Ethiopia that we might talk about as entering the scene in the future, but it's really going to depend on what happens with Nigeria's fertility declines. I've pulled here the different variants, the different possible projections from the United Nations for how quickly Nigeria's fertility might fall. Obviously, if it stays where it is today, that would be the constant fertility. The median age is really low, 18 years old. But I always include it just to keep our eyes understanding that, oh, I hope my internet's working, that if nothing changes, this is what happens. I think it's always important to include that because, again, it's never just about an automatic process. But we do see tremendous difference in terms of the potential median ages for Nigeria. Now, they could follow none of these paths. Botswana actually had higher fertility than Nigeria in 1950. But even under the UN's high fertility scenario for Nigeria, they wouldn't get to the, under the high scenario, they don't get to today's fertility for Botswana, which is 2.89 children per woman, until after 2090. Under the medium scenario, until after 2065. And even under the low scenario, they don't achieve the fertility of Botswana today until after 2050. And it could go faster than that, but it might not. So it's all about, I want to encourage us to think about what has to happen to there. Okay, finally, what happens after the demographic dividend? So to think in terms of the window closing. In China, the country went from a youthful age structure to a mature age structure, really in a matter of decades. India, in contrast, the pace has been slower. Thus, the rise in median age has been much more gradual. But we do know that once the fertility starts to decline, the future is pretty clear. The future is clear. You will be an older country one day. Your median age will be old. And so while a country has the benefit of a relatively large labor force and relatively few dependents, it's a crucial time to establish sustainable pension and retirement policies. It's possible, although we need more research on this, that austere reforms would be more palatable when the population is younger than when those who have the political power are older and they see themselves as having more of a vested interest in them. And we've seen how difficult it is for a country like France, for example, to raise its pensionable age by even 2 years. So in Western Europe, for example, pensionable ages were set when people weren't even living as long as the pensionable ages. Now we know what's happening, we know better. And so countries have the opportunity to change that. The window is closing for Thailand, for Cuba. It's really already closed if we think about median age for Thailand and for Cuba, which may come as a surprise to many people. Australia and New Zealand, it's coming to a close. Costa Rica, Brazil, Vietnam, Colombia, Iran, Tunisia, and Turkey are on the cusp of their window of opportunity being closed as well. So we'll have to shift in terms of our thinking on these states from considering them in the Middle Ages to seeing them as what we would think of as Canada, the Western Europe today. Thanks very much.
Thank you so much, Jen. That was incredibly illuminating. And we have lots of opportunities for questions. Just to remind our audience on YouTube, please feel free to submit questions as the presenters are presenting on YouTube, or by email at pardee@bu.edu, or you can even tweet out to us at BU Pardee Center, and we'll be collating your questions and answering them and responding to them after Joe's presentation in a few minutes. So without further ado, I'd love to turn over the floor to Joe to speak about the linkages between population, global health, and how does global health contribute to these links in the roles of global governance and the global order in these states that are transitioning. So Joe, by all means, the floor is yours.
Great, thank you. I'm just gonna share my slides. And let me bring this up. Okay, so thanks to Manjari Miller and Mahesh Karra and Pardee Center's Rising Power Initiative for inviting me. Today I'll discuss health policy as a domain of growing importance for rising powers seeking to improve their position in global status hierarchies. So we often think of great powers as expressing power in one of two ways: in relation to economic power, economic size, and also military force projection, military power. But how should we think about how rising powers do this when both those avenues are extremely limited? What if you, for example, in rankings of gross domestic product per capita, you're number 96 in the world? How do you increase your standing in any meaningful way that allows you to stand out among your peer nations and improve your position in global status hierarchies? Now, my academic reference point has been scholarship on the developmental state that has highlighted the role that states can play in spurring processes of industrialization and moving countries up these global hierarchies. And yet we know that not every country is lucky enough to have the institutions or right conditions to foster the next Sony or Samsung, big transnational corporation that catches global attention and seizes the market. What alternative ways do rising powers have of distinguishing themselves in the global arena? Well, existing work emphasizes the role of middle powers in multilateral coalitions. Middle powers expressing their influence through alliances. And for example, this can and often does happen. So the Foreign Policy and Global Health Initiative was launched by foreign ministers of Brazil, France, Indonesia, Norway, Senegal, South Africa, and Thailand in 2006. And it succeeded in putting a number of items on the global health agenda through collaboration together. But sometimes peripheral nations use the expertise they accrue from homegrown successes to improve their standing in hierarchies on their own. Sometimes this is deliberate. Sometimes it's with the help of philanthropic agencies or sponsors who draw attention to their work or fund it. And sometimes big steps are taken that have less to do with health policies themselves than broader processes of socioeconomic development. These are often hard to disentangle. Sometimes big jumps, achievements in the health arena are a byproduct of political administration. Rwanda is a dictatorship under Paul Kagame in a region of the world not otherwise known for health and development success stories. It boasts gains that Doctors Without Borders representatives have described as the most dramatic in the world has seen in the last 50 years. Now, as I said, donors and philanthropic foundations like Rockefeller have played an important role in drawing attention to success stories and broadcasting the accomplishments of lower and middle income countries. For example, through their Good Health and Low Cost initiative, now over 30 years old. This played an important role in highlighting important improvements in health outcomes that other countries could learn from in China, Costa Rica, Sri Lanka, and Kerala, and help these countries get recognition for the work they've done to improve health outcomes. Recent retrospective work in this area has explored how these countries and 5 new ones, Bangladesh, Ethiopia, Kyrgyzstan, Tamil Nadu, and Thailand, got recognition specifically for their accomplishments in health system strengthening. Now, sometimes commitment to health policy innovations is a deliberate state project, and sometimes it has specific political and ideological purposes in mind. And the most famous of these is, of course, the Cuban Doctors Program that started after the 1959 Cuban Revolution. In 2019, the UN has estimated that there are over 30,000 Cuban doctors active in nearly 70 countries. And since 1963, more than 500,000 Cuban workers, health workers, have provided medical services to more than 150 countries. This doctor diplomacy has been an important part of international struggles, even with the recent Ebola outbreaks and the COVID pandemic. But this is all to say, though, too, the global development efforts have traditionally focused our attention on improving material conditions, as illustrated in those rankings of global gross domestic product per capita. They've trained our attention on rising GDP, for example, rather than on cultural processes of jockeying for prestige in global status hierarchies. Yet rising GDP and falling poverty are not the only potent hallmarks of development. A country's achievements in other realms, including the production of innovative social policies, may also produce highly symbolic marks of distinction that make nations stand out among their peers. And so work that I'm beginning to do explores how peripheral nations sometimes use this expertise they accrue from homegrown policy successes in non-economic policy areas to improve their standing in these global status hierarchies. Now, what's interesting is that while a focus on development of reputations in health policy, even though it might seem like a logical avenue for rising powers to pursue as a means for increasing soft power, it's actually not so straightforward, even if it's logical. One, these countries face incredible resource constraints, right? Developing policy innovations that catch global attention can be really difficult when you can't throw money at the problem. And then they face additional difficulty of broadcasting their successes when they have limited means to do so at their disposal. Second, health policy is complex. In my book, Achieving Access, I say next to the human brain, health reform is complex. Now, in the fight against the coronavirus, we've seen that countries in the global south have proven very capable in producing good coronavirus responses, and rich countries like the US, Great Britain, have at times really fallen on their face. But it remains still that medical expertise is frequently scarce in the developing world, that the number of doctors, nurses, and skilled providers is being relative to the population is very low in the global south, and further face pressures of brain drain. And so these are factors that might make us think that, well, we're not going to see this all that often, even though the logic might suggest that we should. And still, we know this is attractive for a number of reasons for governments. One, symbolic capital has use to governments. Expertise can help position countries as brokers between global north and global south countries. And it can allow countries that have rising power status to lead on some important issues rather than just have influence in international affairs through coalitions and alliances. Now, my book, Achieving Access, Professional Movements and the Politics of Health Universalism, explored how middle-income nations like Thailand, with limited resource-constrained budgets, produced surprising policy successes in costly areas, looking at, for example, universal health coverage and AIDS treatment. And I want to suggest that by leveraging some of these homegrown successes and providing technical assistance that shares with other nations what countries like Thailand have done, industrializing nations can wield important but less visible forms of soft power. So to share with you a little bit of Thailand's story, in 2001, the Thai government initiated this program called the 30 baht to cure every disease card. 30 baht was at the time equivalent to about 75 cents and meant that everyone could go to a hospital or clinic as they need, present one of these cards, and see a doctor, be rendered a diagnosis and treatment. And now, while the benefit package was limited at the beginning, it has grown since to include cancer drugs, drugs for mental health, dialysis, HIV/AIDS treatment. And so this program was especially impressive in that it took two existing state health insurance programs, and it consolidated them, and then expanded coverage to the rest of the population, with only at the time a few percentage points of the population still remaining to register in the new program. But these, and this program had dramatic effects on Thailand, improving financial protection, preventing people from going out of bankruptcy, increasing use of the services by people in need, allowing people to access new benefits, and building important linkages within the health system. And no less than Amartya Sen and Sir Michael Marmot have drawn attention to this program. And we see it featured in places around the world, including the World Health Organization's notable 2010 World Health Organization report on sustainable financing for universal health coverage, which has been codified in the Sustainable Development Goals in Target 3.8. And we see here, rather than technical statistics or jargon opening the report, a story about Thailand's, an experience of one of Thailand's patients once they had a motorcycle accident, what happened in Thailand. But it's not just in areas like universal coverage where rising powers are making their influence felt. It's also in areas like AIDS treatment, which I covered in my book as well. So Brazil had become known as a model for bringing pharmaceutical companies, powerful pharmaceutical companies, to the table to negotiate and bring down drug prices by threatening to invoke compulsory licensing on needed AIDS medication. Thailand then took this one step further in invoking the first compulsory license, which legally allowed under the WTO Thailand to break patent on first line efavirenz drugs and second line ritonavir, leponavir for AIDS, and then even more importantly on different drugs for non-communicable disease, which represented a really important new precedent-setting kind of position. One that's really important given the growing role of non-communicable disease in the industrializing world. And Brazil found great inspiration for this, as we see from this quote in my book. Now, coronavirus, we're here at this moment where there are life and death stakes. The world is a very unequal place, and countries are trying to jockey to distinguish themselves and save lives. And this is a pandemic, again, that has made a mockery of the responses of rich countries to prevention. We know that the US has had one of the worst responses in the world, even as it has come to start to really roll out vaccine coverage in a big way recently. But stories like one in the New York Times on Thailand, no one knows what Thailand is doing right, but so far it's working. In the National Geographic, a look inside Thailand, which prevented coronavirus from gaining a foothold. Countries in the industrializing world are getting noticed. And we see increasingly new metrics, right, that draw attention to the progress of different countries. And again, there's been so much that's been written on the capture of vaccines by the developed world, and not just vaccines, but also PPE, and that this has been a real problem and maybe a gigantic problem for containing the virus globally if vaccine distribution does not become more equitable. And so national vaccine diplomacy has become big headlines in the world. We see a recent article that's drawn attention to access to the amount of production of different vaccines and the way in which, through various companies, countries are nationally using vaccine production to not only increase their standing in the world through aid, but also leverage over more resource-constrained countries who don't have access to those vaccines. And this is not unlike earlier efforts around AIDS medication, for example. And we see other ways that countries are trying to make a mark and distinguish themselves in this new battle against the coronavirus. India, South Africa's waiver proposal to make vaccine access more affordable has gotten a lot of attention in recent days and months. And sometimes we also know that countries' response to the coronavirus, can have negative impacts on their work to distinguish themselves. While South Africa has had a very, a very sort of imagination capturing role in discussions of intellectual property and AIDS vaccine, while its aggressive response to the coronavirus initially through lockdown got a lot of attention, there has been a lot of challenges that they faced that have mirrored in some important ways the country's own response to the AIDS epidemic under Mbeki. And I share this book here with you that's just been published, that's out on the web today, and I have a chapter that's featured on that. In current work that I'm just going to be deepening next year on sabbatical, I'm really looking at how through a current Fulbright funded book project and some collaborative article projects, how Thailand has managed to produce policy models in a number of different areas and earn a reputation around the world for global expertise, not just in universal coverage and essential medicine, but a number of areas. And you see some of those areas here. And so it turns out, that there's a number of questions that this kind of project gives rise to. How has Thailand been able to do this and do it so consistently? What mechanisms have led Thailand's policy models to travel abroad? More broadly, how does a nation on the global periphery exercise influence in international affairs and increase its standing? Now, we know that, at least initially from my work, it looks as if the development of expertise and reputation across a number of policy areas is a gradual one that occurs in fits and starts with synergistic effects that spill over to different other related policy domains. And Thailand's social movements in Thailand have played an important role in this initially in the development of expertise in a number of policy areas. That reputational rewards a country reaps from their positioning as an expert in health policy do not always accrue to the people and organizations responsible for creating the policy innovation. It can become of use to the governments themselves more broadly, not just ministries of public health, for example, and that these reputational rewards can have good and bad consequences. They can enhance reputation and lead to sharing of lessons, but they can also obscure policy failures or worse. But this international acclaim can also be used by reformers to press for further reform back home. So I'll stop there and look forward to conversation.
Great. Thank you so much, Joe. We have several questions from the audience that I've been collating, and I would love it if we can go through some of them. I actually have a couple for Jen to start. And then, Joe, there are a few that I think audience members have been posting for us as well. So the first question goes out to Jen around migration policy. And the question from the audience was, how does migration policy impact the demographic dividend? And how do states at different points in the demographic transition react differently to immigration and emigration?
Great question. Typically, and this is just typical, so there's always exceptions, but countries with very youthful populations, many countries in Africa, for example, they don't welcome of immigrants who would compete with the native population for jobs. So we do see that as countries move more, these things would be correlated, but as a country rises in terms of its income, of course, it becomes more as a place for immigration. One example might be Mexico. So Mexico has seen a rise in the number of asylees who are applying to stay in Mexico. And that's a shift from where it was in terms of Mexico being a transit point to get to the United States. And part of that, I think, is a reflection of Mexico's rising median age and them entering into a different demographic stratus. So the question that we have is, over the next few decades, do we see countries like China opening more and more to immigration? We certainly see that countries that have been in the window of opportunity but have skills shortages in terms of high-skilled jobs are open to having immigrants come in and fill those. So, For example, Saudi Arabia has a tremendous number of workers coming in to fill its jobs working in oil fields. But so immigration often fills in where there's a mismatch between the skills and the labor. So that's one thing there. What was the second part of that question?
So the second part of the question was, how do states at different points in the transition react differently to immigration? So
yeah. Okay. And I would say universally, however, is a fear of the composition change that comes along with immigration. And I would say that is universal historically, demographically, regionally, and so on. So whenever immigration brings with it, people don't just move, they move their politics, they move their religion, they move their values. And so we do see universally that when there's an influx of immigrants, there's often a perception that something's changing that people don't like. People are resistant to that. So that can often play out in terms of politics. It can play out in terms of violence. If we're not talking about a country that has really high state capacity and the people feel the need to go outside of the state in order to act on their fears, then we end up with things like genocide even. But even in places, democracies where people would work through institutions, we still see the same level of fear of change. Yeah, unfortunately.
Great. So I have a question for Joe, and then we have another question for Jen. I'm going to see if we can alternate because there are several audience members who seem to be very active, which is great. So Joe, one question is there a necessary condition for states to achieve in terms of their health system, capacity and state of health and human capital in order for them to be considered a rising power? So even taking the example of Thailand that you've been walking us through, what were some of the conditions and determinants that you would consider to be necessary in order for such a model to be emulated and replicated across other contexts? Beyond even just South and Southeast Asia, which has seemed to be, connecting back to what Jen was saying, seemed to be rising in terms of even its demographic transition.
Yeah, so these are great questions. We want to learn how these lessons can be applied in other places, right? So, that said, I, of course, as an academic, want to be careful to circumscribe my findings, at least as I'm considering them right now. I've been looking at Thailand for some time and know the case quite well and its work in different policy areas. But that is Thailand's success, right? And there are many different ways that countries approach earning these reputations, and not every health problem is alike, right? They require different kinds of expertise and the like. So I just want to say that. But some of the things that I think strike me as important factors in Thailand's story are the development of a critical mass of expertise in different policy domains that have gotten attention, nationally. So, there can be some nurturing of information that's shared across different domains and begin to consider the ways in which other policy domains might also be built out to support new innovations in those areas, and that helps the health system as a whole. I think it's also interesting in Thailand's case that while some of that expertise was nourished through things like the Rocky Ducks program, through the Rockefeller Foundation and other scholarships to study at globally renowned institutions sponsored by organizations like WHO, EU, that it's also important that in Thailand, expertise is not confined just to universities, that you have important institutions that are parastatal, that stand at arm's length from the Ministry of Public Health, that generate knowledge and contribute to new policy solutions. And that means that expertise is really close to the state, but it's also not completely defined by the bureaucracy of the state. And that can be a really double-edged sword sometimes. And so I think Thailand offers a lot to share. And there's also things I could say about Thailand's relationship to different important strategic, powerful actors at the international level, both foundations, international organizations, international NGOs. But for right now, for lack of time, I'll just stop there.
a lot of the points that you had mentioned about the role of bureaucracy in institutions, and especially the leadership, actually brings us to our next question, which is to Jen, and it's about China. The question from the audience was that China cannot implement common sense solutions to its demographic challenges because they are politically difficult, raising retirement age, more immigration. So does China have any viable options to prevent a shrinking labor pool from dragging down its economy, given its current age structure, demographic transition profile?
I would say that one of the things more research on, I know I've said that about 3 times, but it's because we really do need more research on it. But it's what I'm really most interested in researching, is thinking less about official policies and more about, I've been calling it cultures of work. I don't know if that's the right way to phrase it or not, but even if you look across the OECD and you look at the official retirement age, and then you look at the effective retirement age, there's a huge gap and there's tremendous diversity. So in countries like Japan and South Korea, for example, the official retirement age is below the effective retirement age. And so in those 2 countries, people have been pushing to make the labor market more flexible so that people could actually stay in the workforce longer, get rid of mandatory retirement, and so on and so forth. Because people are living so much longer and they're living longer healthier, they often want to stay in the workforce longer. But that's certainly not the case everywhere. Countries like Greece, for example, the effective retirement age is actually below the official retirement age. And that's because Germany, for example, people exit the labor force through alternative means, such as taking disability and then never going back into the labor force. So I would say that if we're only thinking about how do you change, this is for America as well, how do you change the retirement age? Most people are savvy enough to understand what it means to have a policy to change retirement age, and they would resist it. But if you really look deep into the policies, you'd see that there's really a rainbow of policies that you could actually change that could affect your labor pool, such as disability schemes and so on, that might not attract as much political attention, but still have this a positive effect. The second thing is to think about bringing underutilized segments into the workforce. So Japan, for example, has been trying to do this. I think while demographically the workforce shrank by 8% numbers wise, in actuality, it only shrank by 1% pre-COVID because of efforts to help older people stay in the workforce longer and to bring women into the workforce. So in countries, China is a little different story, but in general, women are an underutilized segment of the workforce. Trying to institute policies to make it easier for them to do so can help.
No, that's a really good point. And I think that a lot of, I mean, the gender dividend is as important to be recognized as the demographic one. So that's a really great point. Joe, I have a question for you about the role of health systems and how that's distinct from health expenditures. Just to give a couple statistics, like the US spends more than any other country in the world per capita on health. We are, I think, at like $11,000 per person per year, which is about 17% of our GDP goes into health. And yet, when we look at our rankings by any standard metric like life expectancy, we are, I think, 46th or something in the world. In contrast, like I was just actually looking at Thailand's numbers, and so the Thai expenditure per person is around $379 per year, which is about 3.8% of their GDP per capita. And yet they're about like 65th or 68th in the world in terms of life expectancy. So there doesn't seem to be much of a correlation when we're talking about health expenditures and health investments, if we consider health expenditure as an investment, and health outcomes, and how that plays into the whole global politic on like health status as a means of ranking and social order. So I was wondering if you could comment a little bit about that, and like what should states, particularly those that are transitioning from like low and middle income, consider just beyond just health expenditure and health investment, and how is that linked to where they fall in terms of the global order?
So yeah, I love this question. So one of my favorite things to discuss in my intro to sociology classes and sociology of health and healthcare classes is comparative healthcare systems. And my students learn, even though they think of the US healthcare system as many people do, as being really great, that it's actually inequitable, that there are real problems in terms of access, that we pay more than any other country in the world by far and get much less for our money, that many of our critical outcome measures, including maternal mortality, are moving in the wrong direction, that there are dramatic and disproportionate impacts on people by race. And so these are real issues, and you can't sweep these things under the rug, and it really disrupts and unsettles people's ideas going in. And so, I turn them on to different ways that countries can finance and organize healthcare, and show them that different assumptions that they may take for granted are not in fact the case. And there's nothing like that kind of comparison, and of course what we're seeing right now with the coronavirus, to really drive home the fact that we can learn a whole lot from other countries. And on healthcare systems, many countries are doing incredible things at much lower costs, right? And it's really critical, I think, to get that story out, not just for the United States, but also for other peer countries, right, who similarly seek to move down those roads towards, for example, universal coverage. But I think you're quite right that the sort of linkage between expenditures and outcomes is a tenuous one, right? We don't always see getting more when we spend more, and so we got to refocus our attention on, how do we get more for less? And of course, different international initiatives like the Good Health at Low Cost study 25 or 30 years ago were important, but there's increasing attention on how to do that within health systems. And of course, health systems aren't the only area where we can have health innovations, right? And so there's lots of increasing areas of domain like health technology where we're seeing people do, and a lot of peer south to south learning go on right now.
Thank you. Yeah, there's so much more to unpack in that question. And actually, one question that I actually had for both of you, and actually we'll see if we can take this in order. And I'm also wary of the time because we're maybe running a little short on time. It's about the policy relevance and the impact, and how can we reach policymakers and stakeholders and states on these types of questions. And the reason why I think it'd be important for us to discuss this is because investments in health and in health systems, thinking about health system considerations, as well as thinking about the role of population and demographic transitions, are all long-term. They're medium to longer-term investments that may extend well beyond the life cycle of a politician. And so the one question that I would have is that, given these lags, and I'm particularly thinking about demographic transitions, where the consequences and outcomes of transitions today are actually the result of behaviors and policies from 20 to 40 years ago. Given these lags, like, how should governments and states consider the role of population and demographic transitions, and complement to Joe, like health systems investments today, in their policy and planning agendas for future positioning, right?
Yeah. The reason I included Tunisia at the beginning is to make sure that we keep in mind that demographic transition could, much like democratic transition, is sometimes a bloody thing. And so I think one thing that resonates with policymakers is to think, all right, you might institute family planning programs, put in place even urbanization, for example. You might put in place the structural demographic conditions in terms of distribution of age and population within the country. But if there are no jobs for people, you've just fed our motive and opportunity for people to rise up against you. What we saw in East Asia was that there were jobs for people. And so they reaped a lot of their demographic dividend. But in places where they've been in the window of opportunity, but they didn't put that in place, there's a tremendous rising resentment and low opportunity cost of engaging in revolutionary or rebellious behavior. So I think that's one of the things that tends to resonate in terms of what else besides lowering fertility could you do? Do you think broadly about foreign direct investment, about business climates, about trade relationships, about literacy, health, and so on? Yeah.
Great. Joe, similar question with health systems, because again, a lot of the discussion around health and population are intertwined, especially when we think about South and Southeast Asian countries that are aging, right? So what are some of the considerations that need to be put in today, and what incentives do politicians and do governments have to make investments today to like possibly not be able to see some of those returns for 20 to 30 years?
Yeah, so great question. Thank you so much. Well, as you rightly note, I mean, populations are aging, and particularly we see this in Asia. And I think that, one thing in terms of incentives is that, we know that aging populations or older populations are often active voters, right? And so this, might be something that helps get the attention of politicians. And, here in the United States, AARP, not an insubstantial player in politics, right? And so it's if a politician is trying to stake out a constituency and make issues their own, then health systems, I think, just thinking demographically, are going to be really important because people need care. When you're older, more vulnerable, you're going to need different things dealt with. How do you do that, and how do you do it cost effectively? Also, I just want to emphasize again that we are in a pandemic, and pandemics are not going away, right? A strong health system can support pandemic response, right? Disease stands to spread much less when people are not afraid of going to the doctor out of fear of becoming medically bankrupt. And so there's a lot of reasons, right? Protecting the health of populations, preventing the spread of infection, ensuring that our old people have a place to go when they need services, and that those services can be provided cost effectively. These are all, I think, important reasons. And that's quite apart from the point of wanting to be a leader and known for these innovations among your peers.
Great, thank you so much. We have maybe time for one or two more questions. So this question I think is directed more to Jen. So during the COVID-19 pandemic, fertility rates have declined around many places around the world. Separately, research suggests that humankind may be losing its ability to procreate. So given these developments, do you think we will be soon sharply lowering our forecast for future global population and have to manage with the situation of more rapidly aging societies?
Oh, probably yes. I mean, and I would be curious to see what you think about this too, Mahesh, but of course it's going to be partly that people are delaying. I think anytime that we've seen these types of disruptive world events or disruptive domestic events, people just put off having children. But I think one difference could be that lead me to think that we will see an acceleration is that rising age at first marriage, rising age at first birth means that people are potentially older. And I actually think we will see a small percentage, but a percentage of people who will find themselves perhaps aged out of the group in order to have children.
Yeah, I mean, I think that like that's such an interesting thing to think about, because we often think about fertility in the context of low and middle income countries as like fertility is high, and what are we thinking about in terms of fertility decline, right? But we often don't come to the point where we have to think about incentivizing fertility to rise again, particularly in contexts where like fertility has fallen below replacement rate. And actually there have been a lot of studies, and something which we unfortunately have not had an opportunity to talk about is the interconnectedness between population health and the environment, where like environmental considerations, climate change actually do have effects on human reproduction. And we just don't know enough about those interconnected links and those relationships to understand how human fertility and fecundity are actually changing as a result of global systemic changes that are not actually attributable to any one given country. And I think that's going to also have a major role in terms of health, in terms of human health, and how we mitigate and regulate conditions around diseases that are environmentally driven that we may have no control. We can't attribute or like place specific burdens or losses to, which makes it even more challenging for states to create programs to mitigate these issues. But these are all challenges that I think that as the world becomes more interconnected, we're going to have to face, from population to health and eventually to like development and security. With that, it looks like we might be out of time. So without taking more time, I would really like to thank both of you. Thank you so much, Jen. Thank you, Joe, for such an illuminating discussion. And I want to thank our audience who've been participating very actively on YouTube. Once again, I would like to quickly inform the audience that for any additional updates on the Rising Powers Initiative, please visit our website at bu.edu/Pardee/research/RPI. And please join our mailing list. And we look forward to having more of these incredible conversations with our experts and faculty affiliates in the future. Thank you very much again for your participation. It's been great.
Thank you.
Thank you. Great.